Hello, good afternoon. This is GIT Surgery Revision from MRCS Rubens Academy courses. We will start with Dr. Alex. Okay, here you are, Dr. Alex. Dr. Alex.
Sorry, I got muted again there, Dr. Reda. The program is true except for the fact that it's only used for colorectal surgery.
So, regarding the enhanced recovery after surgery program, this will optimize the rehabilitation following major surgery. Of course, this is the main aim of this program, reduce the hospital stay, and patient engagement is an integral part. You have to involve the patient, and the blocking afferent painful stimuli is important because pain management is very important, but it's not only for colorectal surgery.
Yeah.
Okay, so although the concept of ERAS was originally started in colorectal surgery, now it is used across all surgical specialties. Pre-admission, we have the nutrition support, cessation of smoking, control of alcohol intake, and medical optimization for the anesthesia, and available pre-operative information for the nurse staff. This is pre-admission. Pre-operative, selective bowel preparation, not routine, and pre-operative carbohydrates, as you remember, and post-operative nausea and vomiting, and reduce the nail by mouse duration. Intraoperative, we can use minimally invasive laparoscopic surgery, and we can minimize the drain and the tubes and give regional anesthesia and opioid sparing analgesia or anesthesia, balanced fluids, temperature control, and the post-operative, we can remove earlier. We can remove the drains and the tubes as soon as we can. Stop IV fluids, not recommended because it will ask you about IV fluids. So please remember that post-operative IV fluids are not recommended. Multimodal opioid sparing pain control. So try to avoid opioids. Early mobilization, early oral intake of fluids and solids, rather IV fluids, and post-discharge for follow-up plan. This is called the ERAS. Okay, thank you, Dr. Alex. Okay, Dr. Aman Arora.
Hello, Dr. Reda.
Hello, Dr. Aman Arora. Here you are.
A 45-year-old man presents with anorexia with pain in the upper abdomen associated with high-grade fever, night sweats, and general malaise for 5 days. The pain is constant in right upper abdomen and is exacerbated by movement and coughing. He had bloody diarrhea over the preceding 3 to 4 weeks. On examination, there is tender hepatomegaly 5 cm below the right costal margin, with intercostal tenderness in the right 5th, 6th, and 7th spaces. As the patient is having fever, we can think in terms of pyogenic liver abscess, and the pain is constant in the right upper abdomen and is exerted movement and coughing. But he's also having bloody diarrhea. So I think the diagnosis should be amoebic liver abscess.
Excellent. Thank you for including all parts of the question to reach the correct diagnosis. Again, in MRCS, you will find two similar question options or answer options that are very fitting for the option, and you can sort it like two options correct. But try to include all sentences and lines in your question. He had bloody diarrhea. This is not haphazardly posted to the question. This is posted to the question to inform you about intestinal amoebiasis. Okay, so the amoebic dysentery, which is caused by epithelial cell infection and then sloughing and bloody diarrhea, this is amoebiasis of the intestine and complicated by amoebic liver abscess. So amoebic liver abscess is the correct answer. And we can see that the amoebic liver abscess caused by Entamoeba histolytica, common in the Indian countries, Africa and South America, can be involved. The majority are asymptomatic carriers. And the most common extraintestinal manifestation is amoebic liver abscess. It occurs but less than 10% of the infected population and in endemic areas. And please note that this is much more common than the bacterial or biogenic liver abscess. The common presentation is young male adult with right upper quadrant pain, fever, and non-specific symptoms of fever, anorexia, headache, malaise, night sweating, cough, weight loss, yes, because of the emaciation and the chronicity, and maybe because of the acuteness of the illness. Later on, it will be right upper quadrant pain, localized more, shoulder tip pain, and hiccups and non-productive cough. Past history of bloody diarrhea or travel to pandemic areas in the index of suspicion. Examination can reveal that the patient is toxic, anemic, and rigidity with hepatomegaly. Next question. Thank you, Dr. Aman Arora, and Dr. Mansour now can answer this question for us. Please note that these questions are not in any question bank known to you. Why? Because we are trying to varying your brains and your ability to solve MRCS question. So please participate with me because it's very important for you to be of variable minds, okay? So Dr. Mansour, try to be away of the noisy background and all other, we are 25 now. Can we raise our hand, Dr. Muhammad Farid, Dr. Galaxy Tab A, Dr. Sharouk Malik, Dr. Shahd, Dr. Qazi? We must all participate, please. Thank you, Dr. Ahmed Al-Jindi, and Dr. Mansour now is on board.
So, a 45-year-old sheep farmer complains about casually enlarging painful lump in the right upper abdomen for 3 months. He is otherwise healthy. Physical examination reveals formed tender hepatomegaly. He has total lymphocyte count of 8,600 with differential lymphocyte count showing 12% is not helped. And options for alpha mycetoma and liver abscess, symptom tuberculosis, hereditary disease, and biogenic liver abscess. So, all sheep farmer. So painful lump in the right upper abdomen for 3 months.
So we will also be with Dr. Ahmed Al-Jindi if you just help us because his voice is unclear. So yeah, try to read the question together. Okay. Yes, Dr. Ahmed Al-Jindi.
Hi, Mr. Reda. How are you?
I'm fine, thank you.
45-year-old sheep farmer complains about gradually enlarging painful lump in the right upper abdomen for 3 months. He is otherwise healthy. Physical examination reveals firm tender hepatomegaly. He has a total leukocytic count of 8600 with a differential leukocytic count showing 12% eosinophils. Options: actinomycetoma, amoebic liver abscess, idiopathic TB, hydatid disease, pyogenic liver abscess. I will go with hydatid disease because he is a sheep farmer and painful lump in the right upper abdomen. I will go for hydatid disease.
Okay, so
Usually,
why if
usually
he's
comes
the
with-
farmer, you will go with hydatid disease?
he is a sheep farmer.
What is the definitive? What is the definitive host of hydatid disease? Anyone knows? Anyone knows what is the definitive host of hydatid disease? It's quietly not uncommon disease nowadays because you can find in the UK patients without hydatid disease, and they are farmers. So you are correct.
If I'm right.
Anyone knows what is the definitive host of hydatid disease? Can you post in the chat? Okay.
Maybe it's the sheepdog.
The dog. Yes, it is the dog.
Yes.
Okay, so you're correct. Your answer is correct. It is hydatid disease. And the hydatid disease called dog tapeworm. Why? Because the dog is a definitive host and it's caused by Echinococcus granulosus, common in the tropics, but in the UK may affect rural sheep farming community. The presentation is a sheep farmer who is otherwise healthy, complaining of a gradual enlarging painful mass in the right upper quadrant with physical finding of liver swelling. Hydatid liver cyst should be considered. Common sites: the liver, next, the lungs. The disease may be asymptomatic, discovered incidentally at post-mortem examination, or when ultrasound or CT scan done for any other reason. Symptoms: swelling, right upper quadrant pain, and the pain is dull, stretching the liver capsule, and the pulmonary lesion can be found and can cause dyspnea. Do you know the treatment of hydatid liver abscess?
I think mebendazole.
Albendazole, yes.
Yes.
And what else? Anyone knows? I will now allow you to open the mic. Allow participants. Okay.
It's the
So
pair
we-
treatment.
We can inject
So
normal
we-
saline
Ini-
into the cyst.
Sorry?
We can inject normal saline into the cysts, and we should wait until it for its removal.
Who
It's
else?
the pair treatment.
Metronidazole.
With
Mebendazole.
It's the pair treatment.
If abscess has developed, then it has to be drained.
So it might be radical surgery with pre and post administration of albendazole. This is the best treatment option due to low recurrence and low complication rates. Some people do percutaneous drainage with albendazole therapy. And please note that they are afraid of rupture of the hydatid liver cyst because of anaphylactic shock.
Anaphylactic shock.
Okay, so next question, Dr. Avinash. Thank you, Dr. Ahmed Al-Jindi.
Thank you.
Dr. Avinash.
Yes, good evening. 45-year-old man complains of burning the epigastric pain that wakes him up at the night. The pain is relieved by eating or using the over-the-counter the antacids and the H2 blockers. Diagnosis is best confirmed by which of the following: urea breath test, serum gastrin level, barium meal examination, upper endoscopy and biopsy. I think the patient is suffering from gastric ulcers.
Gastric.
The diagnosis should be confirmed by the upper endoscopy.
Excellent. So OGD is the best tool for diagnosing peptic, which is a stomach or a duodenal ulcer.
Thank you very much,
Do
Dr.
you know what about urea breath test? Which diagnosis this test is used for?
I
H.
think
pylori infection.
H.
H.
pylori.
pylori.
Yeah,
infection.
for the Helicobacter pylori.
What is the idea? That the H. pylori secretes what?
Urease.
Urease, yes.
Urease.
Excellent. So the upper GI endoscopy is the main diagnostic tool for duodenal or gastric ulcer, and findings of gastritis and the presence of H. pylori are indications to prescribe the triple therapy. This typically include BPI and 2 antibiotics. One regimen include amoxicillin and clarithromycin. Although the urea breath test is the most sensitive and specific test used to H. pylori, it's not easily available in all settings. Okay, so Dr. MBA, next question, please. Thank you, Dr. Avinash. Dr.
Thank you.
MBA. Okay, Dr.
Hello? Hello, can you hear me?
Yeah, of course.
All right. A 45-year-old man presented with a long-standing heartburn, especially at night. He uses 3 pillows to sleep and has medicated himself with variety of antacid over the 15 years. Recently, he has been complaining of dysphagia that has localized in the precordial area. What is the most likely diagnosis? I'll think this is a 45-year-old. Then he has heartburn, history of heartburns, and uses pillow to sleep. I'll go for benign peptic stricture of the esophagus.
Very nice. How did you manage to know that? Because it's difficult for all of us.
He may have the history of esophagitis.
Which is caused mainly by what?
Sorry?
Which is caused mainly by what?
Reflux, esophagitis.
Exactly. Yeah, I agree with you. Anyone has any objection?
Why not adenocarcinoma of the esophagus?
Okay.
There's no weight loss. That's why I didn't go for adenocarcinoma.
To say cancer, you have to have his evidence or his presenting symptoms like weight loss, progressive difficulty in swallowing, loss of appetite. But all of this is not here. So again, this 45-year-old gentleman, long history of heartburn, especially at night. So you can say it is Barrett's esophagitis, but still no histological or OGD evidence of this changes. He uses 3 pillows, so he is complaining of reflux heartburn. And he's medicated himself using PPI, H2 blockers, antacids, whatever. Recently has been complaining of dysphagia that is localized to the precordial area. So we have to stop here and think about 2 things. if this dysphagia is malignant, which is before something, the dysphagia before this is the structure, the normal structure on top of gastroesophageal reflux disease. So you cannot jump from gastroesophageal reflux disease and go to Barrett's or cancer without thinking about what's called post-GERD structure, benign one. So your answer is correct. This is benign peptic structure. And we can see here that the benign peptic structure of the esophagus are submucosal fibrotic rings that narrow the lumen, and they occur between 1 to 4 centimeter in length on top of gastroesophageal reflux disease, which is the most common cause. And heartburn may improve because of obstruction to the refluxed bile. Okay. Next question. Thank you, Dr. MBE, Dr. Usman Tariq. And please, other participants, Dr. Arya, Dr. Sharouk, Dr. Qazi, and Dr. Muntasir, please raise your hand. And
Hello, Dr. Reda. Can you hear me, please?
yeah, I hear you. Yes, here you are.
I can't see the next question. Okay, sorry. A 54-year-old man presents with dysphagia, heartburn, belching, and epigastric pain. A barium swallow shows a sliding hiatal hernia and a stricture situated higher than usual in the mid-esophagus. Endoscopic findings suggest Barrett's esophagus, ectopic gastric epithelium lining the esophagus. Marked esophagitis with linear ulcerations are seen during endoscopy. A biopsy shows columnar epithelium at the affected area and normal squamous epithelium above, confirming the diagnosis. What statement is true regarding this condition? So, option A, adenocarcinoma is less common in Barrett's esophagus. No. Most patients do not have associated gastroesophageal reflux. Okay, that can be. Presence of ectopic gastric lining protects against aspiration during sleep. The present treatment is aimed at preventing esophagitis. When strictures form, they are always malignant.
Not always malignant, and ectopic gastric mucosa will not protect against. So in MRCS, how to approach a question and how to sort it, it's like one-time exclusion, one-time try to solve it because you know it is a recall question, so you know it already. So hit the question, hit the answer, and go for the next one. Don't think that.
I think option B is correct.
Sorry?
Option B is correct. Most patients do not have associated gastroesophageal reflux.
I think this is incorrect as well, because you can have gastroesophageal reflux disease. More than 50% of the patient can have gastroesophageal reflux disease, and it is a Barrett's. So I will tell you now two diseases of the esophagus, very important. First of all, incomplete lower esophageal sphincter relaxation, which is called achalasia. Achalasia of the cardia will lead to chronic irritation because of this incomplete relaxation of lower esophageal sphincter that will lead to bichronicity, to dysplastic changes, and then cancer, which is a squamous cell carcinoma. At the same time, because at the same type of this epithelium, which is stratified squamous for the esophagus, it will be converted into squamous cell carcinoma. No change in the epithelium. The epithelium underwent from benign to neoplastic change. So achalasia squamous cell carcinoma. So remember KK, achalasia squamous. But if we have development of reflux, and this reflux acid will change the type of epithelium with time from squamous to columnar. This is called Barrett's esophagitis. It is metaplastic change of the squamous to columnar esophageal epithelium. This change will become adenocarcinoma. So most patients will have associated gastroesophageal reflux disease, and then Barrett's esophagitis, which is metaplastic. Meta means a change. I know you know this, but many people like they are professors and they forgot the pathological process of the change, invasion of the basement membrane, and like this. So you can remember with me that gastroesophageal reflux disease will lead to metaplasia, Barrett's, and then lead to adenocarcinoma. Why adeno? Because if you remember, Latin word adeno means secretory, means gland, because it is columnar type. So it will be adenocarcinoma and not squamous cell carcinoma, because adenocarcinoma will be on top of columnar epithelium. Okay, so this is correct as well. So you are wrong. Okay, so this is correct, but you are trying to exclude, and this is very nice from you. Complete. Adenocarcinoma is less common? No, it's not. Adenocarcinoma is less common? No. Adenocarcinoma will happen on Barrett's esophagitis. So the main treatment of Barrett's is to prevent esophagitis. Do you agree with this?
Yeah.
Yes.
Because it is only remaining answer. So the present treatment is aimed at preventing esophagitis, because Barrett's esophagitis is a pre-malignant condition because of gastroesophageal reflux disease, columnar metaplastic changes, and the cancer risk is 20 to 50-fold increase. And 1/3 of patients present with malignancy. And many cases of adenocarcinoma of esophagus arise from this Barrett's mucosa. Also, there is some risk of developing squamous carcinoma, but this is 8 to 10% of a long-standing reflux, not more. So most cases will develop columnar. Thank you so much. I'm trying to pressing on some questions came before, and they are complicated, but type of like GIT surgery, you can go from esophagus, then stomach diseases, try to see whether you are covering most of the diseases or of GIT or no. So you can go like systematic approach to cover most of the curriculum. Dr. Ahmed Al-Jindi, anyone raising hand apart from Dr. Hal, Dr. Isra, Dr. LPJ, Dr. Farid? Okay, please, Dr. Shadi Haider, Dr. Okay, Dr. Shahadat.
Good evening for everyone.
Good evening.
64 years old man has a long history of heartburn. His barium studies show an irregular ulcerated area in the lower third of his esophagus. There is marked mucosal disruption and overhanging edge. What is the most likely diagnosis? A sliding hernia with GERD, paraesophageal hernia, benign esophageal stricture, squamous carcinoma of esophagus, and adenocarcinoma. There is a heartburn and GERD and overhanging edge, so I will go with adenocarcinoma arising from Barrett's esophagus.
Very nice. I will go with you as well. So it is adenocarcinoma arising in the Barrett's esophagus or esophagus. Okay.
Okay.
So the history of gastroesophageal reflux disease coupled with these findings highly suggestive of adenocarcinoma on top of Barrett's. Squamous is more likely to occur higher up in the middle, 1/3 of the esophagus, and endoscopy biopsy can prove the diagnosis. The patient should be treated surgically by esophagectomy if carcinoma is confirmed. Inoperable upper GI squamous cell carcinoma can be treated with chemoradiography. Survival outcomes similar to surgery with less morbidities. Okay, next one. Thank you, Dr. Shahadat. Dr. Muntasir.
Thank you.
السلام عليكم.
السلام عليكم
عليكم
ورحمة الله
السلام.
وبركاته.
65 years old lawyer has an elective colon resection. On post-operative day number 5, the patient develops fever, leukocytosis, and increasing abdominal pain and distension. Anastomotic leak is suspected. During the preparation for CAT scan, fresh blood and coffee ground are seen in a nasogastric tube. Acute stress gastritis is best diagnosed by upper endoscopy, angiogram, capsule endoscopy, upper GI series, CAT scan. Upper endoscopy.
If this is anastomotic leak per se, which investigation you are going to choose? The CT scan.
CT scan, yes.
Yes, CT scan. But now there is another incident, which is fresh blood and coffee ground vomiting.
Yes.
So now they diagnose as like a gastritis or peptic ulceration or stress or whatever the reason. Which is the best?
The best
will be upper endoscopy. You said upper endoscopy.
Yes, endoscopy.
Okay. Okay. So endoscopic findings range from petechiae to multiple ulcers in the body of the stomach and the duodenum, and can safely be performed at the bedside in the intensive care unit. Because the bleeding may be secondary to a shallow mucosal erosions, the CT scan, upper GI series, and angiogram will not be diagnostic.
Yes.
So again, can be secondary to shallow mucosal erosions, so the CT scan will not demonstrate anything. Capsule endoscopy is sometimes used in the diagnosis of occult gastrointestinal bleeding when other methods have been inconclusive.
Okay.
Very nice. Thank you so much.
Excuse
I
me.
will ask one of you after opening the mic. Thank you, Dr. Muntasir. The difference between Burave syndrome or Burave syndrome and Mallory-Wester. Dr. Abdullah Malik, Dr. We are 32 now, so please, can you help me raising your hand? Dr. Lee, Dr. Sharouk Malik, Dr. Rajiv, Dr. Alex, raise your hand again, no problem. Dr. Arya, okay, Dr. Ali Sukkar. I will open the mic for MBA because MBA is of good voice and of less noisy background. So MBA, are you ready?
All right. Yeah.
You went to a noisy background.
Yeah. Can you hear me now?
Okay, I hear you now.
Yeah. Okay. Good evening. Previously, LD.
No, the first question, I'm sorry. Just
okay.
Give me a brief comparison between Burave syndrome and Mallory-Wester.
Okay. In Burave syndrome is a tear that is due to vomiting following a closed vomiting that's wrenching vomiting that is due to a closed how do you put it now, esophagus against a closed esophagus, I guess. The tear is muscular, it's a mucosal, deep. It's a bigger tear when compared to Mallory's tear. Mallory's tear occur following alcoholic ingestion, and the tear is at the gastroesophageal junction.
Okay, all the sentence I need, it's just single thing. Who is more dangerous? Which is more dangerous? Like, I am the Mallory Wester, and you are the Burel syndrome. Who is more dangerous?
Burel with
syndrome. Why? Because it is a rupture. It's
a rupture. It's a perforated. Yes, it's more. It's perforated.
Mediastinitis and death. But
yes,
Mallory tear, it is submucosal tear. It is self-limiting condition, and whatever the etiology, ingestion of alcohol, without ingestion of alcohol, the etiology does not matter. What does matter is who or which is dangerous. The Burel syndrome is a rupture, can lead to fatal mediastinitis. Mallory tear is submucosal tear that is self-limiting. Okay, so go on with your question now. Thank you.
All right, thank you. A previously LD florist presents to emergency department after vomiting blood in his flower shop. While waiting to be seen, he has another episode of hematemesis. What is the most likely cause of the bleeding? Most likely cause of the bleeding: peptic ulcer disease, Mallory's tears, gastric carcinoma, rectal hernia, esophagitis. This LD man. Sorry.
Yes,
hello.
Go. Yes, go.
So how is vomiting blood, and as a piece of hematemesis. I'll go with peptic ulcer disease.
Yes, this is normal.
Yeah.
This is normal to have like the peptic ulcer disease. If I asking you about the most common cause of hematemesis in this previously healthy florist, so you can say it is peptic ulcer without being afraid from anything. Okay, don't worry. It is peptic ulcer disease because it is the most common cause of upper GI bleeding, and other reasons. And also 80% will stop with conservative measures of PPI. Please note that gastritis, gastric cancer, esophagitis, Mallory Wester, De La Foy lesion, esophageal varices are also can cause upper GI bleeding, but less common than peptic ulcer. Okay, so thank you so much, Dr. MBA. Really, thank you. Dr. Kazi, and then Dr. Rajiv, thank you for raising your hand and be interactive for this session, which is interactive. Okay, Dr. Kazi, here you are.
Hello. So it's a 25 years old man arrives in the emergency department in respiratory distress following a motor vehicle collision. A chest X-ray shows abdominal viscera in left thorax. What is the most likely diagnosis? So it more sounds like an accident or trauma that has caused this to happen. So the options are traumatic rupture of the diaphragm, sliding esophageal hernia, short esophagus with interthoracic stomach, rupture of the esophagus, and Bugattic hernia. So I will go with traumatic rupture of diaphragm.
Very nice. If I asked you about what is the clinical findings by your stethoscope you will see for a traumatic rupture of the diaphragm on examination, what are the features?
So the percussion will be, there will be, first of all, in the auscultation, there will be no breath sounds on the left-hand side as per the injury.
There will be breath sounds or no breath?
No breath sounds on the left-hand side. So you will only have upper lobe that you'll be able to hear on auscultation.
So you mean intestinal sounds?
Yes, you'll be having intestinal sounds. So you'll be having bowel sounds rather than breathing sounds.
Exactly, bowel sounds will be heard in the thorax while you are examining. Very nice. Can you let me know what is the pathophysiology of Bugattic hernia? If you remember, this is like...
It's a congenital hernia, secondary to a defect in the closure of the diaphragm or bringing back to the diaphragm together. It is mainly on the left-hand side that causes the stomach to and some part of the small bowels and the large bowels to go in the thorax.
Congenital due to which defect? Left what?
Left rural defect.
Left pleuroperitoneal membrane defect. So it is left-sided posterolateral diaphragmatic defect called posterior. So it is bad, and because of higher and more dangerous complications affecting breathing, and it's called Bugattic, and due to failure of fusion of the embryonic structure such as the pleuroperitoneal membrane.
Mm-hmm.
Okay. So this is for this. What is the other type of hernia versus Bugattic? What is the name of anterior hernia if it's congenital?
What was the name?
Morgagni.
Morgagni, yeah, Morgagni
hernia. So traumatic rupture of the diaphragm is due to blunt trauma, okay, and associated with intestinal sounds in the thorax, because the bowel sounds reaching from this diaphragmatic rupture into the thorax. Stomach, spleen, colon, omentum can enter the left pleural cavity, and diaphragmatic injury without herniation of the abdominal contents is difficult to diagnose, and patients present with symptoms many years of the initial trauma. Early surgery is indicated, of course.
An alert nursing home patient is unable to swallow because of neurologic diseases and has lost a significant amount of weight. What treatment should be offered? Central hyperelimination, intralipids, nasogastric feeding, cervical esophagotomy, and PEG tube. Neurologic diseases, lost significant amount of weight.
What do you think? What is the nutrition option for treating?
I think that the nutrition option, it would be the what does it call? Intralipids, but the loss of significant amount of weight. Hello?
Yes, hello, I'm with you. A treatment option for this patient. Sorry, nutrition options.
PEG tube. Dr. Reda?
Yes, again, yes.
I'm going with PEG tube.
Percutaneous endoscopic gastrostomy. Again, please try to remember. The nutrition options. It is one lecture made on YouTube. All MRCS questions are included in this one. Okay, so don't forget the nutrition options. This is very easy question. If you have RTA patient, you will insert NG tube in until there is a suspected skull base fracture. You will try to avoid or cautiously introduce gastric, and later on a long term, you will use percutaneous endoscopic gastrostomy. Also, if you have a long-standing neurological disease with a needed way of nutrition, you will select big. Okay, don't forget percutaneous endoscopic gastrostomy. Okay.
Okay.
If I told you there is esophageal perforation, what you are going to do? What is the option for esophageal perforation?
Feeding jejunostomy.
Parental.
Total parenteral nutrition.
Total parental.
TPN.
TPN.
Okay, very nice. So if you have esophagectomy, you will do jejunostomy, feeding jejunostomy during the surgery. But if you have esophageal perforation, you will use total parenteral nutrition. Road traffic accident patient, short term, you will use NG tube. If you have no skull base or suspected skull base fracture. On a long term, over 4 to 6 weeks, you will need a long-term way of feeding, which is percutaneous endoscopic gastrostomy. It is a mushroom tube inserted through the endoscopy. You will put the endoscopy to see by the camera and then put it percutaneously, the mushroom tube or mushroom brain. For okay, so Dr. Muntadir, all. Okay, if you have any noisy background, please be sure that you are unmuting yourself. You are muting yourself. Dr. Komi. Okay, Dr. Komi, Dr. Rajiv, Dr. Qazi. Again, raise your hand. Dr. Shadi. Okay, so percutaneous endoscopic gastrostomy is the option of choice. Again, endoscopic, percutaneous endoscopic gastrostomy is a rapid and safe method and used for a long-term feeding for anyone unable to maintain appropriate calorie intake orally. The procedure is performed under local anesthesia and some sedation. Okay, next question. Okay, Dr. Qazi, Dr. Ibtihal, Dr. Hussam Hamad, Dr. Emmanuel, please raise your hand. Dr. Arij, Dr. Alex again, Dr. Mo. Doctor, there is a doctor. Okay. Dr. Alex, again, Dr. Arya, if you want. Dr. Arij.
Dr. Reda, I can do it if you wish.
Yes, go on.
So a 55-year-old woman presented with a lymph nodal lump over her right supraclavicular area, and the excisional biopsy shows non-Hodgkin's lymphoma. So the options are ultrasound, a contrast-enhanced CT scan, positron emission topography scan, magnetic resonance imaging, or endoluminal ultrasound. So in this, we're going to be looking for how far on the non-Hodgkin's lymphoma has spread. So I'm guessing we're going to be looking for areas to treat with potential chemoradiotherapy. So probably a positron emission scan.
Very nice. So PET-CT, positron emission tomography scan is of a choice for this. And also, if you have unknown primary, what you are going to do? If you have unknown primary, so you have multiple lymphadenopathy without any proven primary cause of this malignancy. You check the lymph nodes, you find any malignant cells. So what is the scan of a choice? It is PET-CT as well. Okay. Thank you, Dr. Qazi. Thank you so much. Again, please mute yourself if you have a noisy background. Okay. So it is positron emission, and again, the positron emission tomography, because the patient has histologically proven non-Hodgkin lymphoma, a PET-CT scan can show active disease and detect the occult and the primary as well. Or the occult, because it is a lymphoma anyways, so it is in the lymph nodes. Okay, next question. We have the same options, but a different question. Dr. Kane Lee.
I can proceed? Can I?
Yes, you can. Thank you, Dr. Yes, you can proceed, and then Dr. Kane, and then Dr. Isra.
35-year-old woman has been admitted as an emergency with right upper quadrant pain, pyrexia, and vomiting. On examination, she is toxic with a positive Murphy sign. Ultrasound will be the choice.
Ultrasound, why?
Because positive Murphy sign, right upper quadrant pain, and pyrexia and vomiting. She is mostly cholecystitis, and she is woman also. This is more pushing to be cholecystitis. So ultrasound to diagnose the cholecystitis if there is any gallstones or any other problem.
Okay, I need to ask you a question. If you have a patient with elevated amylase triple than the normal and right upper quadrant pain, and the patient around 39 years of age, and you are suspecting pancreatitis, which scan you are going to request for this gentleman?
Can I answer? Contrast enhanced.
Pancreatitis.
Can I answer?
Can I answer, Dr. Reda?
Yes, you can answer, yes.
Me, Dr. Reda? You're telling me?
Yes, I'm telling you.
Yes, we can use this contrast enhanced CT scan.
No, wrong answer. The previous doctor. Wrong answer.
I think it's ultrasound scan because you need to find the cause of pancreatitis.
Very nice. So again, you want to rule out any gallstone pancreatitis. You will never ask for CT scan in pancreatitis until you are searching for complications. This is, I learned this inside the UK, okay?
Yeah.
Because I say, like, I know MRCS and I studied this is pancreatitis, so CT scan. Wrong. We are not going to request CT scan for a pancreatitis without searching specifically for one complication, like, this is maybe a pancreatic pseudocyst. This is a known pancreatitis guy for you, and this is the 15th admission for this lady or this guy for a pain control because of chronicity of the pancreatitis. You are searching for pseudocyst, you can request CT scan. Other than this, the initial diagnostic tool for pancreatitis is a clinical and then ultrasound to rule out any gallstone. And you can search also for other causes like steroid use, hyperlipidemia, hypercalcemia, hyperparathyroidism, and you put idiopathic as a last reason. Okay, very nice. So I gave you the mic, you answered wrong. Okay, but no problem, because I previously believed that this is a CT scan. Okay, Dr. Komi, is
sorry, one question.
Yes.
If option say MRCP, will we select MRCP?
If ultrasound is inconclusive for detecting CBD stone in a patient with rising alkaline phosphatase, then MRCP of clinical importance, and it is indicated. Again, if you have a CBD stone and demonstrated by ultrasound, what is the need for MRCP? Because it is imaging. So now you have a conclusive ultrasound saying that there is CBD stone. Okay. Next step is extraction of the stone by ERCP. Is that okay with you?
Yeah, it's okay.
But if ultrasound is inconclusive for any stones or dilatation with no proven cause for this dilatation, like CBD 8 or 10 or whatever, or 12 or 16, and you have no reason, you might have cholangiocarcinoma, you might have a stricture, you might have a stone, so you are going to use magnetic resonance cholangiopancreatography because because ultrasound was inconclusive, and you will put this for the MRCP guy saying that MRCP is indicated because ultrasound was inconclusive. Okay, so ultrasound, and again, the patient clinically suffering from acute cholecystitis. Ultrasound of the abdomen is the first initial diagnostic tool to confirm the diagnosis, and it can show thickened gallbladder, polycystic fluid, and gallstones. And it may show also CBD dilatation as well. Okay. Next question, Dr. Where is Dr. Isra? Thank you, Dr. Komi. You are very nice. Dr. Isra Hayawi. Yes.
Hi there.
Hi.
A 64-year-old woman is admitted to the hospital with abdominal pain, vomiting, and abdominal distension. Bowel sound are increased on auscultation, and the plain film show a marked distension of loops of bowel with a non-specific pattern. Management following rehydration and electrolyte balance correction should initially involve which of the following? Okay. Nasogastric suction, rehydration, and observation, anticholinergic drugs, laxative, emergency surgery and bowel resection, appendectomy. Okay. From the question, there is small bowel obstruction, I think. Maybe it's adhesional or something like that. We can start by rehydration and electrolyte imbalance. Then I think it is like nasogastric suction, rehydration, and observation.
Exactly. So for this intestinal obstruction for any reason, what is the most common cause of small bowel obstruction?
At this year, if it is pre-surgical, I think it is adhesional, or if it's mechanical, it is paralytic ileus.
Very nice. So it is adhesive cause, okay, due to previous surgery. Okay, if I asked you what is the most common cause of holovesical fistula in the elderly?
It is diverticulitis, I think.
Very nice. And then after, cancer comes.
Yes.
Okay, so you said nasogastric suction, rehydration, and observation as well. yes, it is nasogastric suction, rehydration, and observation, because this is the initial management plan for intestinal obstruction, even with no reason. So correcting fluid and electrolyte imbalances, surgery is indicated if strangulation is happening or anticipated, or if the obstruction fails to respond to conservative management. How many days will you wait? Will you wait 1 day, 4 days, 2 days, 3 days? How many days you will wait and see this conservative? Anyone knows?
Yeah, 72 hours.
Very
Then
nice.
yeah.
Yes, 48 to 72 hours, and then you can say, I'm going for laparotomy, opening this patient. Okay. Nasogastric suction is often effective in obstruction because of adhesion, but it is contraindicated when the obstruction is caused by hernia and or strangulation is suspected. Okay. Thank you so much, Dr. Isra. Very nice to solve all of these questions correct, but this is not all GIT surgery, because we say that we are varying the question pool to increase the gap of from what we study and the exam real questions. Okay, Dr. Arij, and then Dr. Sam. Thank you, Dr. Isra. Dr. Arij, and then Dr. Sam.
Yes, doctor.
Yes, go on.
So, a 42 years old woman is admitted to the emergency department with severe colic pain, vomiting, and abdominal distension. She has not passed stool or flatus for 48 hours. X-ray of the abdomen confirms the presence of a small bowel obstruction. What is the most likely cause of a small bowel obstruction in this patient? I think from the previous question we already answered adhesion.
Very nice. Okay. Okay, adhesions in patients with presenting with small bowel obstruction, clinical exam can usually identify a growing swelling. This attributable to strangulated hernia. If external groin hernia is excluded, the presence of an abdominal scar would highly suggest intestinal obstruction caused by previous surgery adhesions. Peritoneal mets and the primary tumor bands, Crohn's disease, Goldstone Alias must be excluded as well. The distension is mainly as a result of solid air. If the obstruction is proximal, the onset is usually more severe and more rapid. Again, more proximal obstruction up high, the onset will be more rapid and more severe. This is normal. Okay. If you need the second question, Arish, you can
Okay.
take, and Dr. Sam will have another question because your question was answered. Okay, go on.
Yeah, okay. 64 years old man has a benign lesion of the colon. He's informed that the lesion does not predispose to colon cancer. What is the lesion? He has ulcerative colitis, villus adenoma, hyperplastic polyp, adenoma in familial polyposis, colon mucosa in a patient with colon cancer. It's a benign lesion, and his age is elderly, 64. Villus adenoma?
No, no.
Lesion of the colon. He's not describing the lesion, so it's just benign. It's not hyperplastic. Does not predispose to colon. Actually, I'm not sure, but I will answer ulcerative colitis. He's not describing the lesion actually too.
Can I answer?
Can I
Yes.
answer?
You can answer. Yes.
Hyperplastic polyp.
Of course, it is hyperplastic.
Okay.
Again, tubular and vellus adenoma are associated with increased risk of cancer. In part B, there is a section for this. Again, in vellus adenoma, you have
benign.
about hypokalemia because it is secretory for the potassium. Okay.
Yeah, but it's benign.
It is benign, but with a malignant potential.
Okay.
I think it's the most common to transform into a cancer.
I'm not sure, but again, he is asking about the malignant potential, which lesions does not predispose to colon cancer. Ulcerative colitis associated with 5 to 20% risk.
Yes.
Vellus adenoma, tubulovellus, and tubular are associated with about 5 to 20% as well. Hyperplastic polyp, no, it's not. And like
adenoma familiar, yes.
Stomatus polyp of Peace-Jagger syndrome, it is not. And adenoma in familial polyposis, it is 100%
cancer
risk. Colon mucosa in patient with colon carcinoma, it is already carcinoma. Okay,
yes.
so our answer would be hyperplastic polyps, because all the choices listed except hyperplastic polyp are precancerous. Can be in FAP, in ulcerative colitis, can be multicenteric. Large vellus adenomas may be carcinomatous as well. And any patient with a colon carcinoma is predisposed to develop a metachronous lesion in the remaining colon, synchronous lesion, and hence the importance of regular follow-up examination in these patients. Okay. You really, Dr. Arij. Okay, Dr. Sam. Dr. Sam.
Yeah, hello. 25-year-old man complains of rectal bleeding, weight loss, and abdominal pain. He gives history of similar complaint in sibling as well as his mother. Finding on physical examination are unremarkable except for Guyac positive stool. What is most likely diagnosis? Peutz-Jeghers syndrome, familial polyposis of colon, ulcerative colitis, carcinoma of stomach, and Crohn's colitis. Guliac, I think, is to look for occult blood.
Your answer and full explanation.
Familial polyposis because family history.
Very nice. So this is a 25-year-old gentleman, rectal bleeding, weight loss, abdominal pain, and history of a previous complaint for his siblings and his mother. Except for, just 1 minute.
Test for occult blood.
Exactly. It is for fecal occult blood. It is a method for searching for fecal occult blood. Okay, so you said FAB, and your answer is correct.
But now, why can't it be something else?
Which one? Which one can be?
Like Peutz-Jeghers syndrome or anything. Because inflammatory bowel disease also, there will be rectal bleeding, weight loss, abdominal pain, and inflammatory ulcerative like Crohn's colitis. It can be in family also.
Okay, I will start recording and answer this. Okay, so consider it is ulcerative colitis. First of all, ulcerative colitis will not be like this extensive family history. Okay, and it will not be weight loss, will not be fecal occult. Okay, it will be apparent. It is ulcerative colitis. Okay, so it will be apparent one. Bates-Jigger syndrome, he will give you another finding like brownish discoloration of the oral mucosa, so it's not the case. He can complete it as a single disease of the colon, okay? Carcinoma of the stomach is not like this one because this is a 25-year-old gentleman. It's not an old, and it's not Crohn's colitis because, again, yes, this is might be the age, and this is might be of inflammatory bowel origin, but again, you have fecal occult blood, okay? And the Crohn's disease will be like either mentioning the complications or saying like mucus the rectum, okay? So it's not the case as well. So I think you can say it might be Crohn's, might be ulcerative, but when you comes to FAP, it will fit FAP, okay? Fecal occult blood, extensive family history, young age, and weight loss and rectal bleeding. So you will say that it can fit Crohn's, it can fit ulcerative colitis, but it's more fitting with FAP, okay? So again, in MRCS, you can find very close answers, but you can find more correct one. All the clinical features mentioned and the strong family history raise the possibility of FAP. And again, as you said, other possibilities listed may also cause rectal bleeding and abdominal pain, and the strong family history should give a clue to the diagnosis. Okay. And the early onset of invasive carcinoma in these patients marks recognizing FAP very important. Okay, because we said 100% risk. That's why we do follow up and we do surveillance and everything for FAP patients. Okay, and regarding you have asked me yesterday, some of you asked about the NICE guidelines update regarding the follow-up. Is it 1 yearly or 2 year, 3 yearly or 6 monthly? Or it's not important, and it's extensive knowledge because it is subjective, and you cannot judge that this is a high risk, this is a low risk. So it's not asked before. It's mentioned by some of the question banks, but nothing more. Okay. Thank you, Dr. Sam, Dr. Abdel Hamid, Dr. Abdel Hamid, and then Dr. Arya, if you want. And
Yes,
then
sir.
Dr.
Yes.
Hello.
Aman Arora as well. Yes, hello.
Hello, sir.
Hello, Dr. Reda.
Yes, hello, Abdel Hamid, and then Dr. Arya.
Abdel Hamid.
Abdel Hamid.
Okay.
Because you wrote 1E, so it is mid, not need. Okay.
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 It's I. It's not E at all.
انت اللي كاتبها.
ID. ما من زمان بقى غيرها عشان خاطرك كده.
Thank you.
Okay. Thank you. 45-year-old male with a known history of alcoholism is admitted with acute pancreatitis. His serum calcium is 7 mg per deciliter. Management is based upon which of the following? 1/4 of calcium in serum is ionized. Alkalosis increases the ionized calcium component. Hypocalcemia may cause polyuria and polydipsia. Determination of serum albumin is necessary. Treatment should involve intravenous administration of calcium chloride. I think treatment should involve intravenous administration of calcium.
No.
Hi, Dr. Reda.
Yes.
So
Dr.
maybe determination of serum albumin.
Yes.
Exactly.
Yeah,
Yes.
exactly.
Okay. Why I involved this question? I'm thinking about this is a GIT, but I find this question regarding acute pancreatitis with hypocalcemia. So it is very nice to know what are the reasons for hypocalcemia in acute pancreatitis, and then the hypercalcemia and hypocalcemia as an incident. Very important to know, because all informations regarding calcium is very important for all of us, surgeons, medical, any of us, okay? So again, the determination of serum albumin or protein level is very necessary for determining the serum calcium level. Why? Because every 1 gram decrease of serum albumin, the serum calcium level is corrected by 0.8. How this apply? Because if you remember that the value of calcium is the ionized portion, and the other portion is bound to albumin. Okay, so if the albumin, the amount of albumin is going to decrease, this means that the bound inactive calcium bound to albumin will be dislodged, will be free from binding this albumin, and will be ionized as well, will increase the amount of calcium. So we have an equation which is not important for you, but to understand the situation between reduced albumin, so the amount of calcium ionized will increase because it will no longer be bound to albumin. IV administration of calcium chloride is indicated in the presence of symptoms. And please note that 45% of serum calcium is ionized and is responsible for the neuromuscular stability. Half of the calcium, around 50%, is bound to albumin, and an additional 5% is attached to substances other than proteins. Please note that alkalosis decrease the ionized component. Again, alkalosis decrease the ionized content or the ionized portion of the calcium. And acidosis increase the ionized portion. So in severe alkalosis, you are afraid about hypocalcemia. In severe acidosis, you will be afraid about hypercalcemia. And hypercalcemia can cause polydipsia and polyuria as well. Why hypocalcemia in pancreatitis? Mainly two reasons. First reason is due to fluid sequestration, and this will lead to hypocalcemia. A second reason is fat saponification with calcium that might be, in theoretical, lead to hypocalcemia, but it's no strong evidence regarding this. Okay, and please note regarding the enzymes, the autodigestion of the pancreas in pancreatitis is caused by trypsin. The pseudocyst can contain amylase containing fluid. In pancreatitis, more specific is lipase, but why we are requesting amylase? Again, in pancreatitis, lipase is more specific, but why we are requesting amylase? Because simply lipase test is not routinely existing in all settings. What is the value of amylase or lipase to say this is pancreatitis? Triple than the normal. So again, Lipase is more specific in pancreatitis, but it's not present in all settings, in all labs. So that's why we are requesting amylase. Why amylase is not that specific? Because it appears too late within 48 hours and disappear earlier. And also there are many reasons of hyperamylesemia apart from pancreatitis. Again, steatorrhea in pancreatitis caused by lipase deficiency, and this is caused by pancreatic insufficiency. Again, diabetes can happen because of pancreatic insufficiency as well, because of insulin affection. Hemorrhagic pancreatitis will be by ellastasis, and traumatic fat necrosis is a type of necrosis can happen in pancreatitis. Enzymatic fat necrosis, traumatic in the breast, and enzymatic fat necrosis can happen in pancreatitis. Why? Because it is caused by lipase. Okay, so it is enzymatic, not traumatic as in the breast. Okay, Dr. Abdelhamid, thank you, Dr. Abdelhamid. Dr. Arya, you want to answer, right?
Thank you, Dr. Reda.
Yes, sir.
Thank
Okay.
you, Hamid.
I will try, sir. An 85-year-old man is brought to the hospital with a 2-day history of nausea and vomiting. He has not passed gas or moved his bowels for the last 5 days. Abdominal film show dilated small bowel, no air in the rectum, and air in the biliary tree. Okay, no. Which of the following statement is true? Air in the biliary tree associated with the small bowel obstruction suggests Goldstone Alias. I think air in the biliary tree is small bowel obstruction. An enterotomy should be distal to the site of obstruction and the stone should be removed. The scenario is called it's an obstruction. Is it, sir?
Of course, yes.
And
there is air in the biliary tree. There is hemobilia. So
Can I answer?
no, we can give her a chance and then you can answer. Dr. Arya.
Oh yes, I am confused actually.
Yeah, if you cannot answer, he can, because he is apparently can give us bullets in all A to E options. Yes, you can answer now.
So if air in biliary tree
Dr. Arya, are you?
Yes, hand over. Okay.
So air in the biliary tree associated with small bowel obstruction can suggest Goldstone Alias. Is that correct or no? Do you understand what is Goldstone Alias?
Hello?
Yes. Do you understand what is
Goldstone? Yes, good.
Alias?
It's an obstruction. The stone is impacted in the ileum, the ileocecal junction.
Very nice. So air in the biliary tree associated with small bowel obstruction can suggest Goldstone Alias. This is correct. Yes. An enterotomy should be distal to the site of obstruction and the stone should be removed. It's not distal and the stone should be removed. Goldstone Alias is more common in the young adults. I'm not sure. Cholecystectomy is contraindicated. It's not contraindicated. It is debated and it's not at the same session. Small bowel obstruction usually occur in the distal ileum.
Yes.
It is distal jejunum. It is ileum, not jejunum. So the most correct one is A. And we can read together the explanation that Goldstone Alias because it results from cholecystoenteric fistula and is seen more often in elderly patients, not young. And obstruction can occur in the terminal ileum most often, and the treatment is laparotomy, enterotomy, removal of the stone, so enterotomy, which is proximal to the obstruction, and cholecystectomy should be done if the patient can tolerate the additional surgery. Okay. So just 1 minute, please. Give me 1 minute. So I will resume recording now. So just to understand the Goldstone Alias, I know some surgeons are here, general surgeons, so they understand what's Goldstone Alias when you say it is Goldstone Alias, but some of us are orthopedic surgeons. So for us to understand, it is approximation of this edge from this edge, okay? Or from the, like, from here, so you will find this stone approximated in this here, okay? So I can draw it as if the gallbladder is here, okay? And the stone will be here. So it is approximating now. So with time, a cholecystoduodenal fistula will be formed, and then a stone will be moving from the gallbladder to the intestine through this fistula, okay, and move here. And then go to the terminal ileum. This stone will be 2 centimeters or above, and it will be causing obstruction, okay? Once this is obstruction happen, now it is called Goldstone Alias. Alias means paralysis or obstruction of the ileum. So now no option apart from doing enterotomy. What is enterotomy? It is, you will see, this is the ileum. You will open this is by your blade. You will open enterotomy, and you will remove this stone, will be extracted from this enterotomy outside the small intestine, and you can do cholecystectomy if patient tolerates. But most of the surgeons will close the operation like this and do a cholecystectomy later on. This is called Goldstone Alias. Again, in this situation, why you will find air in the biliary tree? Because simply you have a fistula here, so, and you have air, normally you have air in your GIT, right? But not normally to have air in this biliary tree. So the air will move from the GIT through this fistula to the biliary tree. So in abdo X-ray, you can find air in the biliary tree, which is called hemobilia. Hemobilia, okay? So don't forget this.
Pneumobilia.
Yeah, pneumobilia, okay, sorry. Yeah, hemo is blood, pneumo is air. Very nice. Okay.
Okay, thank you,
Next
sir.
one.
Okay, thank you, sir.
Sorry, Dr. Reda, last one question, sorry.
Yes.
Where does ampulla of Vater open in duodenum? This, I think.
Posterolateral.
Okay.
Posterolateral. If you see from my drawing, I haven't drawn it like 100%, but it is like in the posterolateral area, okay? If this is, sorry to, yeah, if this is the C duodenum here, it will open here, okay? So it is in the it is in the posteromedial.
Posteromedial.
Okay. It will open here from the posterior portion. So it is posteromedial.
Dr. Reda?
Yes.
So why it's distal, it's not it's proximal, not distal?
Anyone got a clue? I have no clue here. So if it's proximal, if this is the ileum.
So diameter of ileum is smaller than jejunum, and as it goes towards IC junction, it becomes smaller. So whenever you remove gallstone, it has to be from place where diameter of bowel is bigger. So that is why you do before in proximal rather than doing distally.
Very nice. So this is a very nice justification, and so because of the diameter then. Okay. Okay, next question.
Dr. Reda, please.
Yes, of course.
Will you post this record to the group?
Yes, of course, after we finish, of course.
Okay, thank you.
Thank you. Dr. Aman Arora, and then anyone raising hand? Dr. Mukesh. Okay.
Yes, doctor, yes.
Yes, Dr. Aman.
45-year-old man with hepatitis C undergoes an uneventful percutaneous liver biopsy. About 6 weeks later, he complains of right upper quadrant pain, is clinically jaundiced with a hemoglobin of 9.2, and is fecal occult blood positive. Which diagnosis best explains this patient's symptom? Hepatocellular carcinoma, chronic hepatitis C, colon carcinoma with liver metastasis, hemophilia, symptomatic cholelithiasis. Full percutaneous liver biopsy. Clinically jaundiced. I have no idea. I have no idea.
Anyone can give us a clue?
I think it is hepatocellular carcinoma.
Hemophilia.
Why hemophilia?
So the liver
Hemophilia.
needle is gone through and he's bled clinical jaundice because of pre-renal and he's having blood in the stool. So he's bleeding into the CBD.
You won't get it 6 weeks down the line.
Very nice. So again, it is hemophilia, as you see, and should be suspected in patient with history of liver trauma who later develop GI bleeding and abdominal pain. Hemophilia appears weeks after the injury, and pain is intermittent, and melena or hematemesis can occur. In this case, the injury is a resultant of melena, and hematemesis can occur as well, and the injury is due to biopsy. The other diseases listed are less likely to explain the findings. So again, hepatitis C undergo uneventful percutaneous biopsy, and later on complaining of dropping hemoglobin and fecal occult blood positive. So it is injury for the biliary tree, and the percutaneous liver biopsy is the incident and is a cause, leads to blood in the biliary tree. The blood in the biliary tree will travel from the biliary tree to the duodenum to reach the GIT and lead to positive fecal occult blood. Okay, it is difficult question, but to be variable thinking in the GIT connected together. Okay, next question. This is very important question regarding Ranson's criteria of the pancreatitis. Okay, any participant, new participant apart, we are 40 or 73, 37 now. So Dr. Alex again, and then Dr. Mansour.
Hi, Dr. Reda.
Yes, hi, Dr. Alex. Yeah, go on.
So a 42-year-old gentleman has consumed more than 3 bottles of vodka weekly over the last 20 years and is admitted with upper abdominal pain radiating to the back with nausea and vomiting. Serum amylase and lipase are both elevated, and a diagnosis of pancreatitis has been made. In determining his prognosis, which of the following factors would cause the greatest concern? Hypercalcemia, age over 40 years, hypoxemia, hyperamylasemia, or elevated lipase. So this question is asking which are factors involved with the Glasgow score.
Modified Glasgow or Ranson's, okay, no problem. Whatever you say.
In regards to severity of the pancreatitis. So hypoxemia is on that criteria. And I can't remember if calcium is. I think it is, but I think it's a low calcium would be the concerning feature. So in this regard, I would put hypoxemia.
Very nice. So Ranson's criteria allow for early identification of patients who have severe pancreatitis. Mortality increases with increasing number of Ranson's criteria scoring. We have 5 criteria of poor prognosis at the time of the admission: age more than 55, white cell count more than 16,000, BM more than 200 milligram per deciliter, AST more than 250, LDH more than 350, lactate dehydrogenase, and during the 48 hours, 6 additional criteria may develop, including hypoxemia, which is BaO2 less than 60 millimeter on room air, base deficit more than 4, this is metabolic acidosis, and fluid requirement of 6 liters because of the sequestration, and hematocrit fall more than 10%, urea blood urea nitrogen increase more than 8 milligram per deciliter, serum calcium decrease more than 8 milligram per deciliter, amylase lipase elevation, may focus attention on the appropriate diagnosis, but amylase fail to correlate with the prognosis. In acute pancreatitis, this is made easy because I'm reading the previous slide and this is not good. So we can put in a schedule like this in a table. And you see here the scoring from 1% mortality when the score is 2, reaching to 100% mortality if the score more than 7. At admission, we have the age, white cell count, BM, lactate dehydrogenase, and AST. And 48 hours after admission, we have another 6 criteria can be added: hematocrit fall, blood urea nitrogen rise, calcium decrease, PaO2 less than 60, base deficit, fluid sequestration more than 6 liters. We have also the modified Glasgow criteria for acute pancreatitis. This is for assessing the severity of acute pancreatitis within the first 48 hours of admission, because if you have a patient of 3 or more positive factors within the first 48 hours, now you can anticipate a severe attack of pancreatitis. So HDU admission referral is considered. Again, why we always calculate the modified Glasgow criteria for acute pancreatitis on admission and repeat this daily, because if you have here inside the UK, if you have 3 or more positive factors within the first 48 hours, you can put in your mind that this is a severe attack of pancreatitis, and the HDU admission or ITU admission is considered. Pancreatitis, remember the word pancreas, PaO2 less than 8 kilopascal, age more than 55 years of age, neutrophils more than 15 this time, calcium less than 2 millimole per liter, renal means urea more than 16 millimole, enzymes LDH more than 600 or AST more than 200, albumin less than 32, sugar more than 10 millimole per liter. We have other risk factors including Balthazar scoring CT system or CT scoring system and Apache 2, which is acute physiology, whatever. So it is Apache 2 scoring system. Thank you, Dr. Alex. Thank you, Mr. Alex. Very nice. Okay, Dr. Anyone new? Anyone new? Dr. Mansour. Thank you, Dr. Alex.
Hello.
Yes, hello.
Am I audible, sir?
Of course.
Yes, sir. So a 70 years old woman present with a tender irreducible mass immediately below and lateral to the pubic tubercle. Plain abdomen X-ray shows intestinal obstruction. What is the likeliest diagnosis? So options are small bowel carcinoma, large bowel carcinoma, adhesions, strangulated inguinal hernia, strangulated femoral hernia. So 70 years one. Oh, yes. So the strangulated femoral hernia.
Very nice. This elderly woman presenting with tender irreducible mass, where is the position? Below and lateral. So consider strangulated femoral hernia until proven otherwise, or obstructed at least, because X-ray, abdo X-ray showing internal obstruction. So please put the strangulated hernia in your mind and be safe, doctor, always. Think about the significant exclusion of the significant diagnosis. Like, how to say this? If you have a patient with a back pain or at least left renal angle pain, now you are thinking to refer this patient to urology, thinking that this patient is acute or might be urosepsis because you have elevated white cell count, might be nephrolithiasis, but you haven't excluded rupture AAA. And I know case reports with this rupture AAA on admission to the A&E with left renal angle or left loin to groin tenderness on examination. You have to ask for lactate. You have to request a CT scan for a patient with acute abdomen with unknown etiology. And you have to think about giving antibiotic in the first 1 hour if acute abdomen documented. And don't rush to say your easy diagnosis. Think about excluding the significant critical diagnosis. Okay.
Okay, sir.
So this might be at the end of the day. I see a case with a ultrasound for a consultant or a doctor diagnosing this as a strangulated left inguinal hernia, and later on this was just infected lipoma at the same position of inguinal region. This strangulated femoral hernia in MRCS can be later on in a real exam lipoma, infected sebaceous cyst, whatever. But why we put the correct answer as a strangulated hernia? Because membership of the Royal College of Surgeons need us to be safe doctors, excluding the critical scenarios first, and then go safe for other scenarios. So strangulated femoral hernia is located below and lateral the pubic tubercle and is more common in the females. Inguinal hernias occur in similar frequencies in females, but comparable when compared to femoral hernia, they are less likely to undergo strangulation. Okay, now I'm going to discuss with you what is the aim of this online course. The aim of this online course to make it very simple for you. Again, to just make you study daily, nothing more. Again, the people who will fail with their own study will fail with any online course. The aim of the course to ensure that you are studying, ensure that you are running in a train. So if you are missed inside, like you don't know how to start even, so now the course failed and you might fail. So you have to know the plan of the course and go through the plan. The result, okay, the method is a Q banks and some box in your hand can be used inside your library. Okay, so you can use variable methods not to get bored of the study. And at the end of the day, you have to have about more than 70% finishing EMRCS and finishing all curriculum of MRCS to say I will pass easily. Again, any topic not understandable for you, you have to go for studying the NICE guidelines. So say you have no clue how to study breast cancer, so you have to search NICE guidelines. And you have to learn inside this course how to search. Okay, like breast cancer NICE guidelines, like advanced breast cancer, or like AAA NICE guidelines. So you have to learn how to search, how to find good picture, how to find the scenario. Lastly, you can pass easily from the first go if you will have a curriculum and daily continuous study. You don't need to study 6 hours per day, just 3 continuous hours, nothing more. Okay, but I failed to continue with you and I finished only upper limb and lower limb and GIT iFiles. No problem. Consider it done and put on your wall in your room like a scheduled something missed. So when you are free watching your Facebook or TV, go to your wall and search for the missed scheduled items and go finishing them. By this way, at the end of the day, you will find yourself comfortable, you will go for your exam comfortable, and you will solve it very easily because I showed the results of many people getting 90% and 93, 92%. So it is doable and they are surgeons. No one is free. Even intern and consultant, no one can leave his job. That's why please try to follow through the study and ask me always, because the idea of the course to have support, to have people asking how's your study going. I finished. Thank you very much and I hope you enjoyed this session. If you have any question, please go on.
Mr. Reda.
So can you explain incision for femoral hernia?
Last question also, doctor. How did you exclude?
I will post the MAC-EVD approach and all approaches inside the Telegram right now. No
Reda.
problem. But again, regarding details inside the operation for approaches, just know the current approach, nothing more. Don't go for details of incision and the drainage. I can give you two important applications for searching the surgery, and I think I given this like Incision Academy and Touch Surgery. These are very important. So I can post this Google store, Touch Surgeon or Touch Surgery, I think, and Incision Academy. I will post this for you. Yeah.
Reda.
Yes. Yes.
Regarding these lectures, how often we will be having these lectures?
Like each topic, we feel that you struggle, and it's very important to understand because many people are not oriented with these topics. So each topic, you are not fully oriented. We can arrange something like this. If you like this way, please let me, because
I like this way.
I'm not happy even the course is automated and 100% is enough. But from time to time, we have to meet. Okay.
Definitely. It's very important.
Yes.
Thank you.
Thank you. Any question again?
Dr. Reda.
Yes.
How did you exclude the inguinal hernia from the last question?
Below and lateral. Again, the inguinal hernia is above and medial. Anyway, above and medial. Direct and indirect, you can diagnose it clinically and intraoperative.
Okay, thank
Below
you.
and lateral, in this elderly female, liable for strangulation, so go for femoral hernia, and which can be strangulated.
Okay, thank you.
Thank you. Okay, thank you. We have reached the end of the session. Thank you very much.
Thank you, Dr. Reda.
Thank you, sir.
Thank you.